Experience 20 years ago made the notion of unprotected left main angioplasty taboo. 10 years ago, experience with baromental stents also proved disappointing. That was then, and this is now. I had the opportunity previously to go directly to the cath lab and interview Dr. Geoffrey Bergman, who is an interventional cardiologist and associate professor of medicine. Left main stenting. Jeff, is this acceptable medical practice, or is this a cath lab gone wild?
No, Holly, I don't think it is the cath lab gone wild. I think that left main stenting is something that should be considered in this day and age. We know a great deal more about our procedures. We don't know a great deal more about medical therapy that should go with those procedures. We know a great deal more about the outcomes from such procedures. And I think that it is now part of what the cath lab should be doing for certain patients.
How have advancements in technologies helped you to do this?
Well, I think the principal improvements have been improvement in stent visibility and design and deliverability, but also drug elution has become a major part of the improvement in results from coronary stenting in general. In addition to that, the technology to visualize the stents after they've been placed by intravascular ultrasound, and the medical therapy that is required to go with that, and our understanding of that medical therapy and how to apply it has also improved immensely over the last few years.
Coronary artery bypass surgery is a great treatment for this disease. Why do we need to be putting catheters there?
Well, I agree with you, Holly. I think that bypass surgery is a wonderful procedure. It's been extensively studied, and we know a great deal about how to do the procedure and the outcomes that we can expect for our patients. But surgery is surgery. It keeps patients in hospital for a long time. It debilitates them for a while afterwards. And very importantly, surgery may not last forever for many of the younger patients who are potential candidates for revascularization.
So Jeff, who are the patients you think who would benefit from this new technology?
I think there are two major groups of patients: those who are at greater risk from surgery itself, and also those patients who are very young, patients in their 40s, even into their 30s in this day and age, who present with serious coronary artery disease.
Tell me about one of your patients.
Well, I brought along today an interesting story from a 40-year-old woman. She had had a malignancy in childhood and had undergone radiation therapy and chemotherapy at the age of 15. At the age of 40, she presented with angina pectoris. Angiography showed that she had now had triple vessel coronary artery disease with involvement of the ostium of the left main coronary artery. After some discussion, this patient was subject to coronary artery bypass surgery. But because of the dense adhesions in the chest related to the previous radiation therapy, only saphenous vein grafts could be used. And 8 months later, she was back with angina pectoris again. Wow. And severely disabled. Repeat angiography, as we can see in this slide, showed that she still had coronary artery disease, but all of her grafts were now occluded. She was back to where she started from.
And only 8 months later.
Only 8 months later.
So what was your approach with her?
Well, this is a very unusual situation, but it seemed clearly something had to be done for this young woman. And after some discussion, we placed stents in the left main and the proximal left anterior descending artery and achieved a beautiful result, as you can see in this slide here.
When you're approaching a patient like this, is there anything else that you do in the cath lab to prepare for such a case?
Well, yes, this is a very different situation. We certainly don't do ad hoc angioplasty. We don't just take patients to the cath lab and put stents in the left main coronary artery every day. These patients need to be very carefully evaluated, and there should be a team approach to the management of patients who are potential candidates for this kind of therapy. And it's very important during the procedure that we take every possible precaution to ensure that the stents are delivered in exactly the right place and are appropriately expanded into the recipient vessels. And also, some patients do require support devices to help the heart tolerate these type of interventional procedures.
How often do you use IVUS to determine adequate stent deployment?
We try to use IVUS for all of these patients when the left main coronary artery is stented.
I understand that adequate stent deployment is really important in getting success in these larger arteries.
Yeah, I think that's very true. It's very important that we know the stents are fully expanded, fully opposed to the wall of the artery, and is expanded as much as we possibly can, because this translates into lower rates of restenosis.
How often do you have to use balloon pumps in these procedures?
It's difficult to give a realistic number for that. It depends on the patient's condition before we start. But many of the older patients, anybody who has impairment of left ventricular function before we start, need this kind of support so that they can tolerate the procedure without any complications.
What antiplatelet therapy do you use in left main stenting?
Well, of course, this is crucial therapy for these patients. I think it's very important that patients should be adequately loaded prior to the procedure and have stable blood levels of both aspirin and clopidogrel before the patients undergo stenting of the left main coronary artery. They should also continue aspirin and clopidogrel after the procedure for at least 12 months with dual therapy, and perhaps for even longer if the patient is able to tolerate these medicines.
I know there have been several multi-center studies investigating left main disease. Tell us about where we are in the literature.
Yeah, there have been a lot of studies over the years that have compared surgery with angioplasty, even starting in the early days of angioplasty alone. But in recent years there have been a number of studies which have looked at the value of drug-eluting stents versus bypass surgery. Of note, the Syntax study performed in Europe was a large study with over 1,800 patients randomized between multivessel angioplasty, including left main disease, and coronary artery bypass surgery.
I know that Syntax trials showed no difference in death rates or myocardial infarctions between the two groups. How did the two groups differ with respect to results?
Well, of course, the groups were equivalent to begin with. The randomization process makes sure that the groups are the same before we start. But at the end of 12 months, the survival rates were the same. However, it's quite clear that the angioplasty group did have recurrent symptoms more often and required more revascularization procedures, further angioplasty. But the surgical group, on the other hand, had a significantly higher rate of stroke, which of course is very disabling for patients.
So how did your patient do?
Well, I'm pleased to say that our patient did very well. We actually have a 1-year follow-up angiogram from this patient, which showed the stents were widely patent with excellent flow in the coronary arteries, and together with that she was symptom-free, leading a normal active life, looking after her young children.